Good morning, good afternoon. Welcome to the session. We're super excited to really hear from our panelists and also to have a discussion about how we translate guideline concordant care into clinical practice and how we finance all of it and also integrate palliative care. So we will get started right away because we have 4 panelists and I want to make sure that we leave a lot of time for questions as well. And so the format of this would be that each of our panelists is going to give a brief presentation, about 7 minutes. And so please put your questions in the chat. And then at the end of their presentations, we'll leave time for questions and a discussion. And I'm really looking forward to an engaging discussion from all of you who are logged in. Thanks so much to the London Global Cancer Week for having us host this panel. And the Penn Center for Global Health for supporting this. And obviously, thanks to all our panelists. So we'll get started right away. Our session is entitled From Policy to Practice, Transforming Cancer Care in Africa by Implementing Guideline Concordant Care. We will start our first presentation with Dr. Nyangazi, and I'm going to introduce her briefly, but she has a lot of accolades, so please look her up afterwards. But Dr. Nyangazi is the technical lead for the Global Breast Cancer Initiative and Integrated Women's Cancers of the World Health Organization. She's an accomplished medical professional with over 15 years of career experience, grounded in clinical practice, and expanded into a senior leadership role at the National Cancer Control Plan in Kenya. She most recently served 5 years as the head of the National Cancer Control Plan in Kenya, where she led the formulation and implementation of various cancer policy documents, notably Kenya's Cancer Policy 2019 to 2030 National Cancer Control Plan. I will let Dr. Nyangazi get started with her presentation. Thank you so much, Dr. Nyangazi.
For the kind introduction, and really it's my pleasure to be able to speak at the London Global Week. I will focus on the topic I have been assigned, which will be on regionalization of cancer, translating the WHO GBCI into practice. So that will be the topic for my discussion. So why a Global Breast Cancer Initiative? As you may be aware, it's the youngest initiative. We have 3 initiatives at the WHO. We have the childhood cancer, cervical cancer, and breast cancer is the youngest, having been launched in 2021. And it's because we found requests from member countries to prioritize breast cancer, being that it's the leading or second leading cause of cancer deaths in 95% of countries. It's also the leading type of cancer in 85% of countries. There is a 60% survival difference between women who have breast cancer in high income versus those in low income countries. So this 60% survival difference is a cause of concern. And in the context of making sure that we address health disparities, breast cancer is a perfect example to make sure that care is equal everywhere. So I will quickly just move to the context of the 3 pillars of the GBCI. We have pillar 1, which is on health promotion for early detection, where we envisage 60% of invasive cancers being diagnosed in stage 1 or 2 to improve chances of cure. We also look at pillar 2, which is around timely diagnosis within 60 days of presentation in a health facility. And last but not least, we have pillar 3, where we envision comprehensive breast cancer management, where more than 80% of breast cancer patients should undergo multimodality treatment without abandonment so that we get good outcomes. So these are basically the highlights of the 3 pillars of the GBCI. And this document is available online. If you just Google, you can be able to get it. And what is important to note is that link strategies are important for effective breast cancer outcomes. So basically implementing all the 3 pillars is important. So focusing on our discussion today, what is guideline concordant care? So from where I sit, delivering treatment that's consistent with established evidence-based clinical guidelines, which aims to really standardize care to improve clinical outcomes as well as quality of life for cancer patients, and ensuring that interventions are equitably implemented in line with national policies to reduce disparities and ensure that costs of care are addressed. So in the context of where we work at WHO, we are looking, for example, at what is available. We know that we have guidelines like ESMO, ACCN, NCCN, and ASCO. And what we're asking ourselves, are these really appropriate in all settings? Not entirely true in most of the, especially African settings. I've just put a slide, for example, from the ESMO, one of the ESMO guidelines, talking about diagnosis and staging of early breast cancer. So you can see we have nuances around digital breast tomosynthesis. Some of these might really not be available in some contexts. And so it brings us to how do we adapt or adopt some of these guidelines to national contexts where we can make sure that what we implement is actually what's feasible in our settings. So just strategically giving you an overview of where we focus on in WHO, we focus on leadership and guidance, providing technical products and country support. And in the GBCI, we are focusing on saving lives of many women from premature deaths, ensuring that we have UHC at the primary healthcare level. So we cover as many people as possible with essential services integrating breast cancer in UHC, improving access to health products and technologies, including medicines and breast cancer diagnostics technologies, and generating knowledge. And we are keen on country adoption, strengthening country capacities and technical guidance. So we are basically working towards UHC. And why is this important? We know that in many countries, cancer is a major cause of out-of-pocket expenditures and poverty, which is creating a vicious cycle and hindering achievement of UHC. So we are looking at how do we have guideline-concordant care that is anchored within national policies so that we have them being part of the essential benefit packages, part of the essential medicines list, part of the essential diagnostic list, and part of the general health financing, so that we have them as part of the NCCP implementation to ensure that we have proper resources allocated to make sure that commodities are available where and when they are needed. So this is just a snapshot on regionalization of the GBCI. So the WHO regions are basically focusing on strategic interventions around supporting countries to make sure there is improved access to various cancer interventions. So this is just one of them I highlighted, where you can see some of the interventions, including best price in healthcare for NCDs, including breast cancer, improving early detection and management of NCDs, including breast cancer, access to affordable and quality medicines and technologies, and access to essential cancer services across the care continuum. So one of the progress indicators is how many countries have evidence-based national guidelines or protocols that are able to look at management of major NCDs, including breast cancer. So you can see it's one of the progress indicators we are monitoring, and we are really keen to support countries in this regard. So what have we observed as some of the challenges in implementing guideline-concordant care? Of course, we are looking at a health system approach, making sure that guidelines are incorporated within the national policies. And this is very important so that we don't have a care that's not linked to national systems. And effective national guidelines require resources to operationalize, and making them part of the national policy ensures sustainability in this regard. As I mentioned, embedding them in the essential benefit package, essential medicine diagnostic lists to some extent, and also making sure we have governance structure that will monitor progress indicators in terms of updating and reviewing national guidelines when and where required. Investments in infrastructure to support guidelines, for example, workforce, medicines, technologies, reducing stockouts, and making sure we sensitize the workforce on available national guidelines and make sure they implement them. Also having mechanisms for reporting, monitoring and evaluation, so we have data informing decisions, both at the policy, facilities level. So I think that's the end of my presentation, just giving you a snapshot of why guideline-concordant care is important, anchoring it to national policies and cancer control planning so that the sustainability and making sure we get resources to address health system challenges and as well as challenges as regards making sure that we have these resources to support the health system to implement the guidelines. Thank you, and over to you, Yehoda.
Thanks so much, Dr. Nyangasi, for giving us that overview of the WHO GBCI. And I think in a few years' time, it will be part of the language where everyone actually understands and knows these guidelines and how they're supposed to translate into practice. So our next speaker is going to be Dr. Aram. So Dr. Aram is, I think everyone in global oncology and oncology in Africa knows him, but briefly, he's a medical oncologist and the executive director of the Uganda Cancer Institute. He's an honorary lecturer at Makerere University. He spearheaded the creation of the East Africa Center of Excellence in Oncology at the Uganda Cancer Institute with a mandate to provide specialized cancer care research and training for the entire East Africa region under the East Africa Community Network of Centers of Excellence. Thank you so much, Dr. Aram, for joining us today. And I'll share your slide. 1 second.
Thank you very much, Yehoda, and a very good afternoon or morning, depending on where you are. I'm so honored to be part of this distinguished team in this presentation. Yeah. My presentation is just going to be very brief. I'll look at the burden of cancer in Africa briefly, and then also the challenges, which are both in the areas of disease and also in the areas of systems, health systems. And then, of course, proposing some approach, and that will anchor us onto the importance of having practices that are hinged on guidelines, or at least some way of making sure that practices are regulated. And I think that is what eventually actually is going to be very helpful in advancing how we provide care in a low resource setting, especially in Africa. The first slide. So this is just to show you the incidence and mortality of major cancers in Africa. And of course, to state that 30% increase in cancer burden is expected in the region. And this is going to be dominated by three major cancers: breast, cervical in women, and prostate in men. And of course, the concern is that cancer continues to receive relatively low public health priority in Africa. Of course, this is bound to change, but it can only change with a lot of emphasis on some of the areas of what I would call challenges, which needs to be addressed. And that takes me to the next slide, which actually is showing some of the factors that are fueling cancer burden in sub-Saharan Africa. And they are quite a number. And number one, of course, we do know that because of improvement in quality of life on the continent, we expect that life expectancy and aging of the population is going to be a factor that is going also to ride on the increased population on the continent. We should not forget HIV is still with us, and I think most of the cancers are still being driven by this. And this is also being complicated further because of improvement in care of HIV and also life expectancy among this population. That means actually they are going to be more at risk of developing cancers, which are related mainly to lifestyle. And then, of course, the infection related malignancies are still with us, the Kaposi sarcomas, HPV with cervical cancers, and then, of course, hepatitis B and hepatitis C, hepatocellular carcinoma. Lifestyle changes with tobacco and alcohol use in the continent is still a major problem. So those are still going to be also factors. And then, of course, poverty and other practices that exposes our population to carcinogenesis. Next slide. For instance, in Uganda, we kind of categorize three major risk factor groups in our population. And you can see that genetic and aging contribute up to 30% of cancers, and then the majority being related to infection, up to 42%. And then the lifestyle factors, the NCDs, etc., contribute 28%. Next. These are the challenges. I would categorize them into two. There are the challenges that are related to cancer control, and number one, of course, being the lack of accurate diagnosis and staging of malignancies. And this is mainly because of the limited pathology infrastructure that we have on the continent, and then, of course, limited access to imaging modalities. Number two, of course, late presentation to treatment, and then abandonment and loss to follow-up. And this is also riding on the back of the fact that most of the patients are presenting with advanced stage diseases, which are difficult to treat, and it may not actually lead to good outcome. And that actually contribute to the majority of the mortality that I've shown earlier. And then number three, lack of access to impactful treatment. And as my previous colleague stated, limited availability and access to drugs and treatment. And then, of course, lack of use of proper guidelines and formularies in the dispensation of treatment. And then, of course, supportive treatment and palliative care is also another challenge areas. Next. And then the health system itself also has issues. Of course, talking of the burden of disease, you need to know, and that is the purview of cancer registration. And you do know that in the continent, we do have very limited access to cancer registries. And then the use of guidelines, as I said, being limited. And of course, also areas that needs improvement would be increased engagement by policymakers in understanding and prioritizing cancer, which is still a problem. And this contrasts greatly with the situation in high-income countries where the health system in itself is actually very healthy and is in place. And that means that meaningful utilization of guidelines will follow because the health system in itself is actually ready for implementation. Next. Of course, the key potential areas that can help us as a starting point, and I would call this as low-hanging fruits. Number one, Africa can be used as a base for doing a number of researches that can inform the areas of challenges that I've just mentioned. Of course, key research questions can actually come out of trying to find out the reason why we do have, especially things like the high incidences of diseases. So that means the research need to be prioritized, and these researches can be in the areas of trying to find out the burden of the diseases and then the causes of the diseases, and all these are at the moment actually lacking. Next. And then, of course, if this is done, these are the potential benefits that can come out of prioritization of research. That means there is going to be strengthening of diagnostic capacity, and this can ride very nicely on the back of research. And then, of course, also improvement in the provision of quality care. And this also goes along with, for instance, implementation of guidelines. There is no point of having guidelines when actually the culture of using guidelines is not there. And this culture can be inculcated through the use of research, especially because the basis for doing research is actually the basis for doing things in a systematic manner. And all these include, for instance, trying to increase the notion of early detection of diseases, as well as accuracy in the estimation of burden of disease. So these are the potential benefits that can come as a result of prioritization of research. And on this, then the use of guidelines can actually rise. Next slide. This is just an example of a framework which we have established at the Uganda Cancer Institute, which inculcates in our practitioners a systematic way of approach to care. And this actually also puts in place the importance of a culture of multidisciplinary kind of approach, a culture of education, and then of also using data as a basis for policy formulation. And the cycle kind of goes round and round. At the center of all this is curiosity, which comes as a result of inculcating a mindset of research. Next. Of course, in addition to research, I think the second important, I would call it area which can actually improve the use of guidelines would be the promotion of notion of collaboration. And this can help in areas like developmental capacity. And that means that there is need for us to kind of encourage, for instance, North-South collaboration. And then we are also beginning to see the importance of South-South collaborations. And this in itself can actually help in the transfer of know-how as well as culture, especially for guidelines. And a good example here, which I can actually quote, is the use of or borrowing of guidelines, like, for instance, the NCCN guidelines, ASCO guidelines, etc. But at the end of the day, through the collaborations, we can actually make these guidelines be adapted to our local conditions. And at the end of the day, we can actually own them and they become part and parcel of how our practices can be done. I'm about to conclude. Next slide. I would say these are the priority areas in as far as collaboration is concerned. I've already elaborated them. Next. So in conclusion, I think with the increased burden of disease, there is need for us to think of how we can revolutionize practices of oncology on the continent, and in particular through research and then collaborations. And I would want to leave this with the emphasis that at the end of the day, it is the commitments of us who are on the continent, be it at the individual, at the governmental or organizational level, that will actually drive our practices towards the guidelines, and then with the aim of improvement of outcome as a result of improved practices. I beg to conclude. Thank you very much.
Thank you so much, Dr. Aaron, for that overview. And I think the discussion will be very exciting, thinking about the different guidelines that are available and how we translate and adapt them to our context. The next presenter will be Dr. Halibale. Dr. This one second. So Dr. Babe and I work very closely in Botswana together. Just introduce her briefly. She's a palliative care specialist at Princess Marina Hospital in Gaborone, Botswana. She is the leading palliative care clinician in Botswana with over 14 years of palliative care experience. She has made significant contributions to the development of palliative care in Botswana, including the development of the National Palliative Care Guidelines and Hospice and Palliative Care Policy. She's also a national champion in the Pain-Free Hospital Initiative. Thank you so much, Dr. Babe, for joining us. I'll share your slides.
Hello.
Yep,
Hi, Yehoda.
I am sharing your slides now.
Oh, great stuff. The internet here is a bit iffy, but I hope I'll be able to do my presentation. Good afternoon, everyone, and thank you so much, Dr. Yehoda, for this opportunity to present. So basically, I'll be talking a little bit about Botswana's perspective in integrating palliative care into a national cancer control plan. So a little bit of a background. We all understand that the development of the National Cancer Control Plan serves as a starting point to allow the integration of palliative care into every health system. And we also are aware that the good policies, they lay such a good groundwork for an effective healthcare system. And this all of this ensures and helps us facilitate the implementation of palliative care programs and allows equitable access for our patients. And we know that the lack of these can lead to unnecessary suffering, and hence the presentation today. I have to say for Botswana, we are very proud that for the WHA, World Health Assembly 6719, but Botswana was part of this, and they actually have done very well from that point. Looking at one of the principles that were laid down at the WHA 6719 regarding making sure that these palliative care policies and also making sure that this is integrated and it's evidence-based and it's equitable to every patient that needs it at that particular time. So we are very grateful that that's where Botswana is. Next slide. So basically, where is Botswana and what does Botswana have? Currently, Botswana does not have a document, a National Cancer Control Plan document. However, there's some progress. We've had a support through International Association of Energy Agency, IAEA, and WHO. I think Mary was part of the team to support us, and the technical working group has been set up that wrote. They had a writing team, and we are at a stage whereby now we are able to we're waiting for the support to be able to write the document, and there's actually funding that has been set aside to be able to write this document. So there is some progress. And the reason I have this next slide where Botswana's palliative care journey is to explain and show you where palliative care has been and what other things that we have done to make sure that palliative care is integrated wholly into the health system in Botswana. Botswana is such a small country. However, I think we have done very well. There's been great strides, especially in the area of palliative care. We currently have a policy, we've had a strategy, we've had some guidelines to make sure that we're able to address all these different areas along for the National Cancer Control Plan. And of late, in the last year, palliative care has been set up as part of the new Ministry of Health structure. It has been set up as a standalone under primary health care, which is a great step because it has always been under community home-based care program. And we are very excited that as we continue making sure that patients have access to different things, including medicines. There's also been some form of training, like the Pain-Free Hospital Initiative projects. There's been issues of planning and thinking about morphine reconstitution, making sure that our patients have access and access to opioids at all times. And we are planning to look out to go over our strategy in the next year, and we'll be hosting African Palliative Care Association conference next year. Next slide. So when you look at this, this is the current model that we have for palliative care. And this model is something that was, when we started the palliative care services that was started back in 2015, it was set up based in the oncology setting. We have an outpatient clinic that is based in the oncology area, but from this particular clinic, we are able to access patients that are seen as a consult. These are patients that are seen in our referral hospital, and these are consults from cancer and non-malignant patients that are seen. And we also have patients that are seen from the public, patients that are seen at home, patients that are seen in the private sector that are referred to this particular clinic. And these patients, for us to make sure and leverage on the current systems that are there, these patients are sent home through what we call a community home-based care program. And this program is available through all the districts, every hospital facility in the country. And we are able to use this because most of these patients, most of these nurses in these services, they are trained, they have some form of basic training in palliative care, but not at a professional, of course, as in-service training. And back to the inpatient from
Dr. Babe, I think Dr. Babe froze for a few minutes.
Hello, sorry about that. Next slide. Okay. What we do in palliative care, we see most of the patients, some of the patients, we see them especially at diagnosis and throughout the treatment. And most of what we do is offer supportive counseling, especially to talk through patients about those that are challenged, that are finding it very difficult to accept their diagnosis, and also to be able to adhere to the treatments that have been offered. We do also see most of the patients, of course, the bulk of our patients that we see is, of course, at end of life. And that is because most of our patients do present, of course, at stage 3 or stage 4. However, this is starting to change as most of the people are learning, and they're able to pick up that they need to come to hospital and be able to get in early. And also through some of the things that we are doing, like the patient navigation trials that we are doing. So we are able to get patients a little bit early, I have to say. So next slide, Yehoda. So for the symptom control and supportive care, how are we able to actually achieve this? We are able to achieve it because currently our Botswana essential medicines, they're all according to the WHO guidelines. We have availability of all the supportive medications that we need in palliative care. And this has been achievable because of the support from the government. We also have opioids accessible and available at every district in Botswana, as long as we have a pharmacist or a pharmacy technician and a prescribing doctor at that facility. Each and every patient in the country can access opioids at the services where they are at. And we also have what we call a minimal healthcare package for community home-based care clients. So all our clients will receive the basic commodities that they need at the lowest level wherever they are. And then we also have what we call hospital and community-based interprofessional members of the team. That has been very helpful in that we have a linkage between this
Dr. Babe, do you want to keep your video off to see if it helps?
Yes, that's off. So anyway, that was what I was just saying about the linkages of interprofessional team members out there in the community, and also that are there in the tertiary hospitals. But the community services that we have, next slide, Yehoda. The community services that are there for patients, we have hospices. We have both the inpatient hospice, we have day hospices. Although they are more in the south of the country, but we have those that are available for making sure that our patients are able to stay at home or stay in these facilities and they're closer to home. We have of course, I've mentioned the community home-based care program through, of course, the public system, through all our local clinics, through the National Ministry of Health, and we also have private community home-based care programs. We also have NGOs that help our patients, of course, to be able to go through this particular, it can be a very difficult journey for most of our patients. Like we have Journey of Hope. Of course, they're based in different areas of Botswana to make sure that they're able to link up with patients. We also have Vital Support Group, and we also have Cancer Association Botswana. I'm only just mentioning a few that work closely with the government. Next slide. So from all this, what have we learned and what has worked very well for us as Botswana? The support from Ministry of Health is key. And we also have to use the services that are already there. What is established? What can you do? Because when we look at the system, how we work, I currently work with a nurse, and there's only two of us. And the work would not be able to achieve it just with these two people. But we are able to use the services that are already there in the community. And we are able, the early referrals to our service, and we're able to intervene at an early time, and we're able to reassure patients to understand that palliative care is not equals to end of life. So patients are able to accept this, and they're able to go through the process of understanding what palliative care is. And we also do what we call a systematic assessment. We make sure that we have checked and ticked all the boxes to make sure that patients have gotten the best that they can from the services that is there. And we allow for active patient involvement in the decisions, as much as a patient is always at the center of the decisions that we make for this particular patient. And we also offer a culturally sensitive care approach. We understand this because we are Botswana. We are able to speak the language. We are able to talk to the patient at the level that they understand, and also accepting and understanding that they all have different beliefs. They have all different, they come from different backgrounds, but we need to also understand that where they are at, it can be difficult for them to understand that they are going through all this because of the cancer, and they ask themselves questions that we cannot even be able to answer, but we are able to accept them and help them where they are. And I think that is my presentation. That's what I wanted to share with you. Thank you so much, team.
Thank you so much for that passionate presentation. And we'll discuss more about how you've been able to decentralize palliative care in Botswana. Our last speaker, last but definitely not the least, because she is going to talk about how we finance all of this, is Dr. Lillian Epo, who is the CEO of the Nigeria Sovereign Investment Authority, Lagos University Teaching Hospital Cancer Center. This is recognized as the leading cancer center of excellence in Nigeria and West Africa. She is a distinguished professional with a Bachelor of Medicine and Surgery degree from the University of Ibadan and an MBA from Warwick Business School. Thank you so much, Dr. Epo, for joining us.
Thank you, Yehoda, for the introduction. Good morning, good afternoon, good evening to everyone on this call. It's my pleasure to be here. I'll be discussing the sustainable financing models for implementing national cancer control plans, and what has this been experience-wise in Nigeria. Oh dear. Seem to be having trouble progressing the slides. Just 1 minute. Let me stop share and start again. Okay, great, working fine now. All right, so I will start from, how did we start as a country in Nigeria? What has the journey been like? In 2018, global cancer statistics regarding cancer in Nigeria were appalling. We had 72,000 deaths from cancer every year, with 102 new cases annually. And the top 5 cancers in both sexes were breast, cervix, and prostate, with colorectal, breast, and cervix being responsible for about 50.3% of the burden. Mortality rates at the time were high, with the likelihood of dying from breast cancer in Nigeria at 51%. That's almost 3 times the rates in the US, where you had a mortality of about 19%. Radiotherapy services at the time were only available in 7 teaching hospitals in the country, and only 2 of these were functional, and they were offering epileptic service. Nigeria has a population of over 200 million, and if all the machines were functional, that would still be a ratio of about 1 machine to 28 million people. And the total spend at this time on medical tourism was estimated at $1 billion US. The top 4 areas of specialty for which people were seeking care outside the shores of Nigeria were oncology, orthopedics, nephrology, and cardiology. Now, 2018, Nigerian government decided, involving all relevant stakeholders, they set out 7 goals in the 2018 to 2022 Cancer Control Plan. The first of which was to make screening services and early detection of cancer available for all Nigerians, to improve access to quality and cost-effective and equitable diagnostic and treatment services for cancer care, to achieve best possible quality of life for patients and families facing life-limiting, threatening, or terminal cancer. 4, to increase cancer awareness and advocate for cancer control amongst the populace. 5, to conduct and support integrated programs that will provide high-quality population and facility-based cancer data for dissemination, research, and planning. 6, to ensure the availability of drugs, consumables, and functional equipment for cancer care in Nigeria. And 7, to ensure effective coordination and adequate resources for cancer care in the country. Now, I will focus mainly, the rest of my discussion will be focused on the goal number 2. What did we do as a country? So I speak to the supply side as regards the availability of services, diagnostic and treatment-wise for cancer in Nigeria. Now, in 2019, the Nigeria, through the Sovereign Wealth Fund managed by the NSIA, which is the Nigerian Sovereign Investment Authority, invested $15 million, and in partnership with the Lagos University Teaching Hospital, which is one of the oldest and foremost teaching hospitals in the country, was able to set up the NSI Youth Cancer Center, which opened its doors in 2019. The center runs as a public-private sector partnership and currently functions as the largest cancer center in West Africa with 3 linear accelerators, and was the first to deploy 3D brachytherapy services in the country. We have seen over 1,000 unique patients since opening, and we offer radiotherapy, both external beam and brachy, chemotherapy and immunotherapy. Sees about 60 new patients weekly, treat about 100 to 120 to 140 patients daily for radiotherapy. From this center alone, current savings to the Nigerian economy in terms of losses from medical tourism is estimated at $300 million US. So this is just a picture of the center, how it looks like in Lagos. So riding on the success of NLCC, the NSI Youth Cancer Center, the Federal Ministry of Health in Nigeria, working through the NSIA, is setting up cancer treatment and nuclear medicine centers in 6 teaching hospitals in the country, 1 in each of the geopolitical zones. And this entire enterprise is being project managed by MedServ. MedServ is a healthcare investment arm of the Nigerian Sovereign Investment Authority. 3 of these centers will be functional by 2025 and the rest by 2026. MedServ on its own is setting up 2 cancer treatment facilities and multiple diagnostic centers as part of its healthcare infrastructure upgrade plan for the country. Now, we know this is a drop in the ocean compared to the infrastructural needs of a population of over 200 million, but it's a far cry from where Nigeria was 5 years ago. And we know that 60% of healthcare in Nigeria is delivered through the private sector in Nigeria. However, like other aspects of medicine, where you have significant private investment in service delivery, you have several private hospitals, all over the country. Because of the huge capital investments needed to set up cancer centers, currently only 3 of the cancer centers in the country are wholly private owned. The 4th one has since fallen to ruins due to this mismanagement. So on the supply side, it's evident that we've only made progress because of significant government investment in oncology. Now, the future challenge will be the maintenance of this equipment, which for now is, for the most part, not sourced locally and is therefore expensive to sustain. Now, to the demand side. We have all the equipment, it's now available across the country, one in each geopolitical zone. How are people able to pay for these services? So on the demand side, we've not made as much progress. We have to understand how people will be able to afford these services now they have become available. 60 to 70% of healthcare services in Nigeria, payment for healthcare, is made out of pocket. The current insurance plans do not cover cancer care routinely, and this is only available to persons engaged in the formal sector of employment. 92% of Nigerians are employed in the informal sector. So you can see it's just a very small portion of the populace that can access cancer care via health insurance. NLCC, for example, runs as a for-purpose enterprise, and 95% of patients pay out of pocket for their care. And a third of patients who present at the center cannot afford the cost of care. So to bridge this gap, the Federal Ministry of Health set up the Cancer Health Fund in 2020. So this is the demand side of things. 2020, the federal government assigned 700 million naira to the Cancer Health Fund. This was set aside to treat the top 3 cancers in the country: cancer of the breast, prostate, and cervix, which accounted for 50% of the cancer burden. The goal was to make at least as big a dent as possible in the burden of cancer within the country. The goal was to have indigent patients access care in designated hospitals in each of the 6 geopolitical zones, to reduce travel, which would increase the cost of care and increase the likelihood of treatment abandonment. Funds were to be lodged in an electronic wallet, with each patient accessing a minimum of 1 million naira for their care. The entire scheme was to be managed electronically for purposes of tracking and transparency, as the hope was to be able to attract additional funding from philanthropic organizations once the project had demonstrated proof of concept successfully. Now, the fund officially took off in 2021, but full implementation was not until 2022. For this reason, further government subventions to the fund continued to shrink. We had 400 million in 2021, 150 million naira in 2022 and 2023. So far, you've had 1,434 patients registered under the scheme and 1.4 billion naira dispersed to patients so far. The scheme has had several challenges. Aside from limited funding, we've had 700 million startup funds in the country with over 200 million people. There's no cover for pediatric cancers. Illiterate patients have been unable to access a wholly electronic platform, and not every person living in the country has access to a smartphone or a computer. So rounding up, it's clear to say that the only way forward is for government to make consistent investments in oncology across all areas: diagnostics, training, treatment, and research, to ensure that it is equipped to handle the anticipated rise in cancer cases predicted for LMICs. Definitely, there's still a lot of work to be done. Thank you very much.
Thank you so much, Dr. Ekpo. I think we will please enter any questions you have in the chat, but we'll just get started with Q&A because we have a few minutes to go. So I think for Dr. Nyangazi and Dr. RM, you both mentioned how guidelines that are used in the sort of global north, they're not adapted for our settings in Africa. And I was just wondering, a lot of the times ministries of health spend so many years trying to develop their own new guidelines. How have you managed to adapt and adopt guidelines in sort of the different settings where you've practiced, so it's efficient and actually prioritizes the common cancers that are seen? And Dr. Ara, maybe you can go, and Dr. Nyangazi.
Yeah, so thank you. I think this is still, I would say, very much a work in progress. And in the past, most centers would want to kind of from scratch develop their own guidelines, and this is quite expensive. Of course, that means it will kind of answer the problem of having something which is specific for the center, as well as the cultural practice in the country, etc. But in most cases, you will not have the funding for that. So we approached it 2 ways. One, is through the region by developing a team to put together guidelines for the East African region. And when we started that, there was an opportunity through the intervention of the American Cancer Society, as well as the Network for the National Cancer Center in the US, that kind of came together with, I think, IBM, and they came up with an idea of setting up a consortium that can actually use the current guidelines that are being used, for instance, in the US, and then adopt them for the sub-Saharan African countries. And that was actually spearheaded by myself and Professor Doyle. We kind of brought together a number of African centers to begin adopting, as well as making the guidelines kind of, I would call it, user-friendly to our kind of environment. And as I speak now, it is actually a very big success. Through the African Cancer Center Coalition, we now have guidelines for almost most of the common cancers, and it's accessible online, and most centers are now using it. Of course, that doesn't address I would say, the final details of some of the challenges that some of our centers do face. But as a start, it's a very good starting point, and maybe it also addresses the issues of cost in terms of developing guidelines. But now the challenge that now remains is the availability of inputs, including drugs, including diagnostic capacity, so that effectively we can use those adopted guidelines to the full capacity. That is our experience. Thank you.
Thank you. Dr.
Thank you.
Nyangazi, how does the WHO GBCR fit into all of these? Because you're not developing your own guidelines. You're just providing guidance for how to implement breast cancer care. And so how are you integrating and thinking about guidelines?
So thanks, Yehoda, for that question. So one of the things we do is actually country support. So we support countries in case they want breast cancer guidelines. But as you heard from Jackson, it's really an expensive process. And that's why we are anchoring it in the government policy, so that as they're developing the NCCP, they factor in the costs for developing some of these, and not just developing, but ensuring that they are put into use. So national guideline development at country level is one of the work that we do, but anchoring it within the NCCPN policy and the broader national health agenda, so that it's financed centrally. The biggest challenge is, of course, reviewing the guidelines. But as Orem has stated very well, we can start with the adaptation through consensus. Ultimately, we should work towards generating evidence and data within Africa to inform guidelines, as happens in the West. And I think we have challenges. For example, Dr. Orem agree with me. We don't have guidelines for example, HIV, patients with HIV living with cancer. And it's because this is not a commonplace in the West. And we will really need to do a lot of evidence generation on what should go into, for example, guidelines to support management, for example, of persons living with HIV, now that they're living longer and getting cancer. So these are some of the things we have looked globally. Research from the African continent is minimal, contributing just 9% of global research. So we really need to do a lot to reach the point where guidelines from African context can also inform care based on our context. Thank you.
Thank you, Dr. Nyangazi. And Dr. Babe, I just wanted to follow up quickly on what Dr. Nyangazi said, because I think when we think about adaptation, palliative care is probably one of the guidelines that needs a lot of cultural adaptation in our setting. You know, there's a lot of culture differences around death and dying. And so I was just wondering if you could comment a little bit about how you have adapted palliative care guidelines in Botswana to be culturally sensitive to some of these issues?
I think I did mention, thanks, Yehoda. I think I did mention that what is important is also allowing our people to be real with us and making sure that these patients understand exactly why we are there. We are not there to impose that which we believe or that which we understand, but we allow them. We have these open conversations with them. We're able to embrace whatever background, whatever belief system. I think, as you know, a lot of African people are very religious. They're very into spiritual things. So the tendency is to believe in this, and it becomes very difficult to penetrate. But if you allow them the space, and if you allow to make sure that they are at the center, we are able to achieve that. I think that is what we are not, just acknowledging that which they believe and making sure that they understand. I think also the positive thing is that being a local and speaking the local language, they're able to hear you more, and they believe that you are very empathic and you are with them and you understand. Thank you.
No, thank you, Dr. Babe. And I have just one more question for Dr. Ekpo. So a lot of the discussions around financing cancer care has actually evolved into a universal health coverage for cancer patients. And what you described is not universal health coverage. And so how exactly? So do you think this is feasible? Is it pie in the sky? How? Because I think if Nigeria can figure it out, most of Africa will be able to figure it out. So how do you reconcile the push for universal health coverage with what you described with the NCO?
So definitely that would be the way to go, because once you have universal health coverage, you have a bigger pie for everyone to share from. There are just more funds available for the care. I think why, and MedServ in conjunction with NICRAT. NICRAT is the organization that is now in control or that supervises and just regulates all activities as regards cancer care in the country. They're doing a significant amount of work just trying to understand how the different costs interplay. What is the cost of radiotherapy? What's the cost of medication? And put all of that in a huge, algorithm and trying to find what is the baseline amount that can actually treat cancer. So when we begin to, as we refine this data, what will actually support it is having, information that's coming from the cancer registries. And thankfully, there's a lot of work on that right now, revamping cancer registries in Abuja, even in Lagos, training, facilitation, equipment that's been dispersed so that we can get the actual data. I mean, what exactly is the burden of cancer and how much does it cost us to treat cancer? When we get all that information and we can plug it in, then you can actually find like a financial model that works. So all of that is still a work in progress. I don't think it's pie in the sky because this is what operates in other countries. There's also, because we've talked a lot about cultural barriers, there's also a lot of education going on regarding insurance, because that's the sort of thing that people shy away from, health insurance in the country, to say, well, nobody plans for, you're saying I'm going to be sick, so I'm paying money in advance for that, but that, is slowly changing. So definitely, I think in the coming years, with all the work that NICRAT, and agencies like MedServ are putting in, we will be able to come slowly towards that.
Thank you so much. And I am glad you said this is not a pie in the sky. So we can definitely work towards that. I don't know, how many years away we are from that, but I really think that is the goal, especially thinking about, the most common cancers that we see at least. So I wanted to end on a positive note. I know we're out of time, but I just wanted, for each of you, can you just, comment on what gives you hope about cancer care in Africa? Like, what makes you, because I think, when we think about the incidence and the prevalence, you're going to have a shift and an increase in burden in Africa. And so when you look at the current landscape, what gives you hope? And can you do that in maybe 1 or 2 sentences and we'll wrap up? Dr. RM?
Thank you. I think what really gives me hope is the fact that our governments are beginning to take note of cancer as actually an important public health issue. And also they are getting more and more receptive despite the fact that the landscape is a bit skewed in terms of availability of resources towards communicable diseases. I see in our region, the East African region, the governments are beginning to put in our own resources in the fight against cancer. So to me, that gives me a lot of hope. Maybe the second thing is the fact that the level of awareness is growing in the population. About the year 2000, when I just started my practice, the level of awareness in Uganda was less than 3%. You cannot believe it. But now we are in excess of about 15%. To me, that trend in itself gives me hope, because that is the key to prevention, the key to effective treatment. When people are aware, then that means actually they are going to present. And of course, that also gives another challenge which needs to be addressed through the provision of services targeting cancer. Thank you.
Thanks, Dr. Aram. Dr. Nyangazi.
Thanks, Yehoda, for this question. I think for me, it's right now there's more focus on cancer, as Dr. Orem has mentioned, and I see hope in terms of, despite our challenges in African context, we're starting to see more survivors, and I see policy advocacy and advocacy really growing in the cancer space. And this is basically an opportunity to shift paradigms in the space of cancer. If you look at the HIV world, really what made a lot of difference was the advocacy from the persons living with HIV. So I see one day some revolution from all the advocacy that's going around, and especially the fact that we have survivors who are doing two things: creating advocacy and reducing stigma, because initially cancer was so much stigmatized. It looked like cancer is death, and I think this is beginning to change. Thank you.
Thank you. Advocacy revolution. Cancer is not dead. Dr. Babe.
I think there is hope, Yehoda. Looking at that, Botswana has at least started with just getting the NCCP plan in paper. I mean, that is a great step towards acceptance. And I believe the Ministry of Health are also understanding that palliative care is key to taking all this, because we are seeing, as the other previous speakers mentioned, we are seeing more and more HIV-related cancers, especially in our country. But what are we doing about it? I think they are listening, and I'm very grateful that they'll continue to listen, and we look forward to change. Thank you so much.
Thank you, Dr. Epo.
Yeah, so several reasons why I'm excited. I'm excited because, just like Ram said, it seems there's a lot of government commitment towards oncology, towards treatment of cancer. I mentioned in my presentation all the cancer centers that are springing up across the country, from 2 basically that we had 5 years ago, and then 6 years ago, and now you're moving to 15. That is like almost like a meteoric rise. And once you have that sort of activity, then everything around it is catalyzed. You have the specialists, the people who are coming in, diagnostics feeds into that. So there's really a lot of hope because there's a lot of activity in that space. I think the other thing is what my colleagues have mentioned already, which is the advocacy. More awareness around cancer. For our World Cancer Days events that we had this year, we had a lot of people from university coming in, awareness about cancer, because part of the struggle that Africa has had has been late presentation, and around a lot of that is surrounded by cultural, issues and myths and things like that. But when you have the younger generation who have an awareness of cancer, that, oh, this growth that I'm seeing is not someone that cursed me, is not a quarrel that I had, is that I'm sick and I need to get to the doctor and I need to get there on time, then certainly give Africa the next 4, 5, 6 years, you will see a significant change.
Thank you so much. And I'm glad you put a timeline on it. Next 4, 5, 6 years, we hope to see that change. But thank you all so much for making the time to join this panel discussion. I think it was really informative, and we didn't get a lot of time to engage the audience in questions. It'll be posted online, so you might get more questions following this discussion. But I just wanted to say thank you all so much for joining us. Thanks to the London Global Cancer Week for having us be a part of this, and also the Penn Center for Global Health for supporting the platform. And thanks so much to our audience who joined as well. And have a good evening, afternoon, good morning, everyone. All right. Yeah.
Thank you.
Thanks,
Thank you so much.
Yehoda.
Bye,
Bye-bye.
everyone.
Thank
Thank
you.
you.
Thank you, everyone.